In this video, we will be demonstrating percutaneous antegrade Holmium laser lithotripsy of upper ureteric stone. We all know upper ureteric stone can be managed in multiple ways. The most commonly performed procedure being ureteroscopic laser lithotripsy. Of course, for a large upper ureteric stone more than 1 to 1.5 centimeter in size, even laparoscopic ureterolithotomy also can be performed. Either transperitoneal or retroperitoneoscopic approach can be done. The third option is percutaneous antegrade laser lithotripsy. All these three approaches have their own pros and cons. Like for example, if you take ureteroscopic laser lithotripsy, it would be the most minimally invasive procedure where you can break the stone completely and the patient can be sent home very early. However, there is a risk of post-operative fever and even sepsis in sometimes those patients where you have a large ureteric stone. The other approach, if you take laparoscopic ureterolithotomy, it has the advantage of removing the stone with single incision, and the risk of fever and sepsis would be lesser. Whereas the percutaneous antegrade approach has the advantage of treating the upper ureteric stone, and also simultaneously you can remove the kidney stones if they are there. That's why in this given case which we are presenting, since the patient had both upper ureteric stone and also some inferior calyceal stone, we have opted for percutaneous antegrade approach. So every procedure has its pros and cons, and the operating urologist has to select the procedure according to the given patient. The index case is a young male patient who had bilateral stones. Like here you can see on the right side there is a large pelvic stone and multiple calyceal stones, and on the left side you can see a large upper ureteric stone of around 1 to 1.5 centimeter in diameter with small stones in the inferior calyx. The patient initially presented with obstructive uropathy, hence bilateral PCN was placed because he was in sepsis before. Now he was planned for definitive management. If you go through the CT scan also here, you can clearly see the bilateral stones, and the upper ureteric stone you can see on the left side. Since the patient had even kidney stones on the left side, he was planned for percutaneous antegrade removal of the upper ureteric stone. Intraoperatively, first ureteric catheter was placed. You can see the upper ureteric stone. So the ureteric catheter initially didn't go beyond the level of the ureteric stone. Hence, the tip of the ureteric catheter is actually kept just below the upper ureteric stone. The patient is placed in prone position and a retrograde pyelogram was done. Now you can see the calyx which I was pointing with an arrow here. See that calyx? So that is the mid posterior calyx. You can see the small air speck is there in that calyx. So why I am selecting this calyx? Because in case of antegrade PCNL, it is very important to select either a middle calyx or a superior calyx so that you can access the upper ureter easily. Now see, using a bullseye technique, I am just focusing on that calyx which I have shown. You can see the tip of the needle is there at that white area where the mid posterior calyx was there. So this calyx, if you see, when I am moving the C-arm, it will turn medially if it is a posterior calyx. Now see, when I did the C-arm rotation, the calyx has moved medially. So the same calyx, that will confirm that there is a posterior calyx there. So since it is turning medially, that white area, if you can clearly observe, we are going to focus that. I am doing a bullseye puncture. See, in 30 degree I am passing the needle inside. So to assess the depth, I have to rotate the C-arm again to 0 degree. So I am passing slowly centimeter by centimeter into that calyx. Now you see, so you can see the calyx at a tip at that the tip of the needle is just on the surface of the calyx. So again I turn the C-arm into 30 degree. Now I am pushing it a little bit inside. So when once you have that giveaway feeling, you will know that see, you can clearly see that white area, it has traversed into the kidney. Now I am removing the stylet. Now that free saline coming from through the puncture needle confirms the position of the needle. Now I am passing the guide wire through the same calyx which I have shown before. Now the guide wire exactly coils in the pelvis. Now the next step is obviously the dilatation of the tract. So you can see the upper ureteric stone as well. Now I started the dilatation of the tract. So using serial Teflon dilators followed by Alkan's cannula. So then subsequently the MIPM system is used for PCNL here. So I am pulling the metallic sheath, outer sheath of the ampla sheath of the MIPM system. See, you can see the calyx where I have entered. You see the infundibulum all around. So this suggests that the perfect puncture was done. So the infundibulum is in front of you means you have entered the calyx through the papilla. Now you see the infundibulum again. I am going again inside. Now you see small stones which are floating in the pelvis. That's the PUJ. So using the eddy currents, because the advantage of mini perc is the saline when it goes inside it creates pressure within the system, and that pressure itself will create an eddy current leading to expulsion of the stones through the sheath easily. Now I am advancing the sheath a little bit inside to reach to the upper ureteric stone. So you can see there is a lot of edema and some polypodal changes at the level of the stone. Since I have punctured a mid posterior calyx, it is very easy for me to access this area because you are actually straight. Now using Holmium Laser lithotripsy with 1 joule energy and 10 Hz frequency, I have started ablating the stone. So it is also very important when you are treating an impacted stone in the ureter not to injure the mucosa of the ureter. So you can see how slowly I am doing bit by bit ablating the stone using the laser. Or whenever any stone is there in the ureter, never exceed your energy beyond 10 watts. So you see slowly I am passing the laser fiber in and out, because that in and out movement of laser fiber will prevent a significant ureteric injury. So you see the stone getting cleared into the form of small fragments as well. And see, I am just started ablating the center of the stone. So in ureter it is always better to break the stone in the center and keep on moving from one area to other area. So this is a standard technique for breaking the stone. Just keep on moving from one area to other. Sometimes you can use the tip of the laser fiber also to disimpact the stone from the mucosa, because these stones they get buried into the mucosa sometimes. So you have to be gentle while treating such stones. So meanwhile I am bringing out the stone fragments using the eddy current. See, coming out again, go in and out. This is the advantage of mini PCNL over RARs, where the removal of small stone fragments is faster. Now you see it's still impacted. We are continually using the laser fiber bit by bit. So always keep on moving the laser fiber. Don't be static at one place. If you keep your laser fiber static, you will tend to injure the mucosa more. See, I'm just kept on moving from one place to other. Yeah, see, one by one, one by one. Now the stone is slowly started moving. So that means significant portion of the stone is being done. Now the only thing that is left is the distal part of the stone. So even if small fragments come, you can easily clear them with the eddy current in antegrade PNL. So this is the terminal part of the stone. See, it is now moving. Now only few fragments are left. So now saline irrigation, go on in and out, clear all those stone fragments. There are some mucosal edematous changes were there, so I am Some of the stone fragments which are embedded in the mucosa, so I am taking them out with the forceps. You see there is some flake like material here which I am pulling with the forceps. So this is very important to clear all these things. See this using the forceps and everything, that's the advantage of antegrade PNL, you know, you can clear the thing very fast. Now almost now I passed a guide wire from below just to know where is the ureteric lumen there. So that is that. So since there is impacted stone, so I plan to place a stent. Now I am looking for any other inferior calyceal stones which are left. So see, with the mid posterior calyx I am actually going into the inferior calyx. So there is a stone here left, so using forceps I am bringing it out. So these are like few secondary stones we can say, because of the obstruction they got formed in the system. So this is the final stone fragment which is left, which we are clearing with the eddy currents. Now you see this is the post complete clearance. Now finally I am passing a double J stent. So in antegrade patient I follow the technique of placing the DJ stent like this. Over the guide wire you position the DJ stent and push it with an artery, hold it with an artery behind proximal and push it the whole assembly inside. So this technique is useful. Now I am positioning the upper coil. See the coil is fine now. Okay. Now after this I am just pulling out the sheath. Now you can see the entry point. See that infundibulum is in front of you. See, that's a good puncture if you do it like that. Thank you.